because the
Hey guys, good evening.
Good evening.
Good evening.
I'm in the process of unmuting everybody here because my expectation is that we will have participation here this evening.
You have entered as an attendee in listen-only mode.
Let's see, who do we have with us here this evening? Bill Wise just joined us. Hi, Bill.
Hi, Mark. How you doing?
Good, man. How about you? Looks like we've got David from Iowa. Is that correct? Or are you... I'm not seeing your last name. David Hod, are you with us?
yes, sir, I am.
Okay, good to meet you. Where are you from?
Myrtle Beach, South Carolina, actually north.
Nice.
Yes.
Yeah, I know exactly where it is. I have a place on Hilton Head.
Okay,
So
nice.
Yeah, so
Oh, I'm
very,
vacationing there soon, Brooks.
How are you?
Yeah, with
Yeah.
my family.
Yeah, I'm going there here in about 3 weeks during spring break there.
Oh,
Yeah.
awesome.
Okay, so we have. That is called reverberation there. So I'm going to let Ganesh go ahead and fix that. Jennifer from Florida is with us.
Hello.
Kajal from New York. Raji from New York.
Hello.
Hello. We've got Richard from Virginia. Richard, you're self-muted, so I'm going to need you at some point to unmute yourself. We've got Roy from Indiana.
Hello.
Hello. Vicky from Oklahoma City here.
Yes, sir.
We have, and Vicky, you've seen these cases. You were at CSM, so this you'll be the expert.
Oh, great.
Yeah. And then we've got SVJ Kumar with us.
Yes.
Hello, sir.
I'm
Have we met?
Hello, sir. No. So, Mark, yeah, we met the last week class in ultrasound.
That's right. That's right. From Houston, Texas, if I'm not mistaken, right?
Yeah. Me and Ganesh together.
Yeah. Excellent. So, let's see if anybody else. I'm going to give it about another 30 seconds and let maybe some late attendees, pop in, and then we're going to go ahead and get started. Guys, what I'm going to do here is, this is a presentation that Dr. Rawat, Dr. McKibben, and myself gave at CSM here a few weeks ago. And it basically revolves around the shoulder and, how we can use either our ultrasound imaging or our electrodiagnostic tests to help us determine what's going on here. So I have a question. We have a question here. Let's see here. Okay, so Richard says I am muted by him, so I have Richard. It's telling me you're self-muted.
Now
I'm
good. I'm
now
here,
you're
Dr.
good.
Brooks.
Good. So anyway, I've got 5 cases that I presented at CSM, and what I'm going to do this evening, I'm going to present the first 3, and basically what we're going to see is, from a physical examination standpoint, and let me go ahead and, okay, this is already recording, so good. I don't want to get in trouble for not recording this. But, from a physical examination standpoint, these patients are pretty much going to present the same, okay? But there are subtle and in some cases major differences in these cases. And unless we as PTs take that next step by either doing ultrasound imaging or doing electrodiagnostic studies, then we're going to miss part of the diagnosis, and we may end up not treating our patients and managing their condition as optimally as we can. Okay. Those of you that have not been on a webinar with me, I am all about you guys asking questions. So feel free to unmute yourself. Just go ahead and knock out a question to me anytime you want. If you're one of these that likes to ask questions, sometimes I get on a roll and I don't look at the little question, panel here. So, go ahead and forgive me in advance for that. Okay. So let's go ahead and begin here. Can everybody see my screen?
Yes.
Yes.
Okay.
Yes.
So
Yes, sir.
Yes, sir.
these are all patients that I've seen in clinic anywhere from the last month or so going back to maybe a year. Okay, so this guy here shows up in your clinic. Is our standard physical therapy evaluation going to be adequate
No.
to assess what's going on with this guy?
No.
Probably not here. Probably not. I mean, obviously, this gentleman, and I believe I'm going to talk about him next week. Obviously, we have some significant issues here. And you can, if you look carefully at his arm, you're going to pick up subtle things that are going to help lead you in the correct direction when doing your diagnostic tests here. Okay, so looking at this guy here, obviously he has significant atrophy of his shoulder girdle. But if you look at his biceps and his triceps, they still look good. Okay. Yep. You can physically see a separation occurring in this guy's shoulder. Also, correct? Okay. So again, we're going to need to know what's wrong with this. Is this purely a musculoskeletal issue? Is this a peripheral nerve issue? Is this a central nervous system issue? Our diagnostic tests can help us get to that proper diagnosis here. Okay, so first case I want to talk about, this is a 71-year-old lady, and I saw her in clinic back last December. And again, like I said earlier, the way they're presenting, it's pretty much going to all sound about the same. Shoulder and arm pain, paresthesias, limited motion, weakness, functional loss. Okay, they're all going to, be presenting with that. This particular patient, reports her symptom onset in September of last year after she fell and fractured her proximal humerus, which then in turn required an ORIF. This lady had extensive therapy for shoulder, for shoulder and arm issues, but had minimal improvements in her range of motion, strength, function. And she reports that her neurological symptoms actually got worse after her surgery. So here is our patient. Okay. Right shoulder, you can see her incision. You can see a little bit of a difference from side to side. Obviously, we got a little bit of a adipose or edema pouch here. Not quite sure what that is. But on observation, it appears that she has atrophy of her shoulder and shoulder girdles with some marked atrophy of her right deltoid here. Range of motion limited throughout. Okay, limited both actively and passively. Basically, from the elbow down, she was normal. Strength-wise, she had weakness throughout her right upper extremity, with particular weakness noted around her shoulder girdles. Reflexes were good. In terms of her sensation loss, she did present with weakness in digits 2, 3, and 5 on that right side. She did have a positive Phelan's test. She had a positive Tinel's test at both the wrist and elbow. region. Okay, so guys, based upon, looks like Kathy Blair has joined us. So Kathy, I got your text about the report you just submitted. And Mark Ward has also joined us from Oklahoma City. Mark, I'm going to try to unmute you. There you go. Mark, say hi.
Hi, guys.
And then I just unmuted Kathy. Hey, Kathy, say hi to everybody. Oh, Kathy's being shy here. So based upon what we're seeing so far, somebody or a couple of three of you, give me some potential differential diagnoses that would present with these symptoms, with these physical examination findings, and with our observational findings. And again, don't be shy. Anybody? Uh-oh, crickets.
5'6".
Possibly 5'6". Okay, because we have some altered sensation in D2. We've got atrophy of some of those proximal muscles. I think I heard Richard say lateral cord again, and he's basing that upon the fact that she appears to have some muscle atrophy here. What would cause paresthesias in digits 3 and digits and in digit 5? What's the most common neuropathy that we see?
Ulnar neuropathy.
What was that?
Yeah. Ulnar neuropathy?
Median neuropathy?
No, not in digit 5.
Yeah, but what would what could cause paresthesia in digit 5? Probably the second most common neuropathy that we see.
Ulnar neuropathy?
Yeah, ulnar neuropathy at the elbow.
Elbow?
Yep. What else could cause paresthesia in digit 5? Sort of working your way up the arm.
All right, given where the fracture occurred, the median and ulnar nerve run down the medial part of the upper arm.
Yeah, in the axillary region, the median and ulnar nerve are in a common neurovascular bundle. So it's possible that this could be a more proximal issue. In terms of paresthesias in digit 5, going even more proximal, it could be a lower trunk medial cord issue, and then even proximal, more proximal than that, it could be a lower cervical issue. Although, lower cervical issues, are fairly rare. Okay, so there's a lot of potential differentials, with this patient. Okay, and this is where doing our imaging and doing our diagnostic, our electrodiagnostic test could be helpful. Okay, so I did sensory and motor nerve conductions on this patient, and you guys are all used to seeing tables in a Cadwell format. I use a Techasynergy system, so a little bit different table layout, but our data is still data. Okay, so take a look at these sensory nerve tests and tell me what's normal and what's normal. And guys, keep in mind when you look at my sensory tables, you'll see this term ortho. I do orthodromic testing. So my norm for amplitude for median and ulnar nerve is 5. Yours is 10. Okay, because you guys do antidromic testing. So, so take a look at these sensory findings and tell me what you see going on here.
Amplitudes seem to look pretty good.
Amplitudes are all good. Yeah,
Yeah.
sensory amplitudes are all good. Okay, so let's look at some of the other.
Latency.
Yeah, latency of what?
Median nerve.
Yeah, median latencies are what?
Delayed.
They're prolonged. The
Prolonged.
correct word to describe latency is prolonged.
Prolonged.
Okay, and in a sensory nerve, if you have a prolonged latency, what else are you going to have?
Nerve conduction velocity decrease. Nerve.
Yeah, you're going to have a slowed conduction velocity. Her median sensory conduction velocities across that wrist are in the 20s here. Whereas if we look at ulnar and if we look at radial, they actually look pretty good.
Yeah.
Okay, so now let's pop down to our motor table here. Okay, for the time being, forget about the axillary nerve. Let's look at median and ulnar. So analyze that data and tell me any potential abnormalities that you see in our median and ulnar motor data.
Well, you got your velocity of your
Median.
elbow, the ulnar,
Yeah, so the ulnar velocity is what, Roy?
29.6.
Yeah, it's slow.
Yeah, it's definitely slow.
Yeah, so from above elbow to below elbow, it's slow. Okay?
Unusual.
Yeah, very slow. Could that explain any of our patient's symptoms?
Absolutely.
Yes.
Absolutely. That could very well explain why she's got that paresthesia in her fifth.
Yeah.
Okay. Look at that median motor
Median.
data. Anything abnormal there?
The latency.
Latency.
Yeah. So our latency is what?
Prolonged.
It is prolonged. Yeah. Yeah. Okay. So it appears that not only does she have the shoulder problem, it also looks like she potentially might have some median neuropathy at the wrist, as evidenced by the prolonged motor latency and our abnormal, median sensory findings. And then she's very likely looks like she has some ulnar neuropathy at the elbow. So would that explain her paresthesias?
Yes.
Yeah. So don't assume that because she's got this horrific problem at the shoulder, maybe, that's what the cause of her paresthesias are. Okay. My mentor a long time ago told me, like 25 years ago, said, Brooks, when you're in the forest, look for the deer, not the unicorns. Okay. The most common cause of hand paresthesias are median and ulnar neuropathies, not the weird stuff. Okay, not plexus issues and things like that. Okay. Now, because she had what appears to be atrophy in her deltoid, I did an axillary motor test, and recorded off of her middle deltoid. Do we see any abnormality here with her axillary nerve?
Not that
And
I can.
again, axillary
really.
nerve, yeah, axillary nerve, these proximal nerves are always done bilaterally because you're comparing amplitudes, side to side. So when we look at this actually looks pretty good.
Yeah.
Okay, there's not a latency difference side to side. There's maybe starting to get a little side to side difference, but that lower amplitude on that right side could very well just be due to some of the atrophy here. Okay, so our nerve conduction tests have pointed us in the direction that she certainly has some median neuropathy at the wrist, and she has some ulnar stuff going on at the elbow there. So let's stick a needle in her and let's see what we find.
Excuse me, Dr. Brooks.
Yes.
Sorry, this is Kajal. Actually, Raji is unmuted by you. She wants you to. She's muted by you.
Well, I didn't mute her, but I certainly will unmute her, and I'm going to go ahead and try to unmute. Nathan Shields has joined us. Hi, Nathan. And Raji. Okay, I'm trying to.
Hello?
There we go.
Can you?
I'm unmuted now.
Yes,
I was muted for a while.
now I can
Okay.
speak.
Yeah, I don't know
Thank you.
why, I don't know why these things will just sort of mute. So I'm gonna, Bill is self-muted, David is self-muted, Ganesh is now
Okay.
unmuted. There we go.
Thank you. Yes.
And Nathan just self-muted himself here. Okay, so I've tried to unmute everybody that I can here. So somehow we got back to here. So let's stick this lady with a needle here and let's see what it showed. Okay, here we go.
Gracias. Gracias.
Okay, so does she have an axillary nerve issue?
No.
No. Does this lady have an upper trunk lateral cord issue?
No.
No.
No. Does this lady have a nerve root issue?
No.
No. What are we seeing in our EMG?
Median nerve.
FDI and
Median nerve at the
APB.
wrist.
Yeah.
Yeah, we're
Polyphasic.
seeing some polyphasic motor units in her,
Yeah.
in her first dorsal interosseous, which fits, with her ulnar neuropathy at the elbow.
Mm-hmm.
And we're also seeing some fast firing polyphasic motor units in her APB, which fits with her median neuropathy at the wrist.
Yep.
Here, okay. So this has nothing to do, with what's happening in her shoulder. Okay, there's a possibility that some of these things could be a result of her arm being immobilized or in a sling or something like that, but none of this explains why she's got the quote unquote air fingers atrophy of her right shoulder. Okay, so based upon her diagnostic test, her electrodiagnostic tests, which showed no evidence of any proximal nerve injury, no evidence of any nerve root injury, what's causing this atrophy?
Disuse.
Disuse.
Yeah.
Absolutely. 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 If she would have had an axillary neuropathy, which 99.9% of the times are axon loss lesions, we would have seen something in her deltoid.
Yep.
Okay.
Yep.
And what's the other muscle that the axillary nerve innervates?
Teres minor.
Teres minor.
Teres minor. Yeah. So middle and anterior deltoid is innervated by the anterior branch of the axillary nerve, and then the posterior deltoid and teres minor is innervated by the posterior branch after it goes through the quadrilateral space. Okay.
Dr. Bruce,
Yes, ma'am.
with this much of atrophy, it doesn't show any change in the EMG? Like muscular part is not.
No, because what we have is we have muscle fiber atrophy. Okay, the fibers are getting smaller, a little bit smaller, but because it's not chronic and because it's not axon loss, we're not seeing any evidence of any muscle fiber degradation at this point. Okay, now, if this continues on for 18 months, okay, and she still doesn't use it, okay, these muscle fibers are going to get used to not being used, and at that point, we might start to see some issues, such as some decreased insertional activity and significantly reduced numbers of functioning.
Recruitment.
Yeah.
Okay.
Yep. Okay.
Okay.
So when we look at her picture here, what we're seeing here is a little bit of a red herring. It appears to be due to disuse. And she could be hurting. The quality of the therapy she was getting might not have been adequate, but what we're seeing here is really not any neurogenic muscle atrophy. Okay, so basically,
It's a good prognosis.
it's an excellent prognosis.
good prognosis.
Provided that her shoulder's not completely frozen up.
Right.
Okay. So again, we have a case here that presents with atrophy. She's got all the symptoms. She's got the pain. She's got the paresthesia. Okay, she's got the decreased function, weakness, atrophy. So the first thing that we think of is, this is something neurological. It's atrophied. So, there's a nerve issue here. And other than those distal issues that we saw down at her elbow and her hand, this really is not anything neurogenic here. So again, we've, using our diagnostic tests, we've determined that as it pertains at least to her shoulder, we do not have any significant, neurological impact. So with proper therapy, with getting some mobilization, she should do well. Okay, she should do really well here. Case 2 saw this young man in clinic last October, and look at the complaints. This time it's on the left shoulder, and as we'll see over this webinar and then the next one I do on the series, it's a bad time for the left shoulder here. Okay, so we got shoulder and arm pain, paresthesias, limited range of motion, weakness, functional loss. Okay, I basically could have cut and pasted this from the previous case and just changed right to left. Symptom onset after a motor vehicle accident in September. September was a bad year for these two folks, or a bad month for these folks also. And he sustained a distal radius and ulna fracture, which required ORIF. Okay, had some physical therapy, had some improvements in range of motion, strength and function of the wrist and hand, but he's saying my shoulder is just not getting better, and if anything, it's actually getting worse. Okay, and the ortho guys that I work with in this big clinic, for some reason they're really hung up on plexus issues. Okay, and if you want to see something that's even more rare than a lower cervical issue, plexus issues, it certainly are. Okay. 5'10", 155 pounds, atrophy, left shoulder girdle, with marked atrophy of his deltoid more than the other ones. He also had atrophy of his left arm and forearm, which could very well be due to some disuse, but we don't know that yet. Okay? We can't assume that. Here's our guy.
Yeah.
Not too bad looking from this angle. Starting to get a little bit of winging going on here, but we'll talk about that more here later. But this is really striking. Looks very similar to that first guy that I pictured. Okay, we have loss of the anterior deltoid. We have loss of the middle deltoid. Posterior deltoid doesn't look too bad yet. Okay. So again, guys, I could have cut and pasted this from the previous slide. Limited range of motion, but normal passive motion, whereas the other patient did not have normal passive motion.
Right.
Significant weakness in that deltoid. We're talking 2 out of 5 strength here. And then somewhat less of a weakness deficit in some of the other muscles. intact reflexes. Oh, and look again. Altered light touch, digits 2, 3, and 5. And very importantly, he had a patch of skin paresthesia on that middle deltoid. Okay, what does that tell you? What nerves give you sensation to digits 2, 3, and 5? We've just been through all of them. Okay. Yeah, median ulnar.
Median and ulnar.
Yeah. What about that loss of sensation on the middle deltoid region? Where is that coming from?
C5.
Orthopedic guys, you should know this. Ortho guys should know this.
C5 and
Yeah.
like musculocutaneous comes off of there, doesn't it?
No.
Lateral cutaneous nerve of the arm.
Okay, so we're all PTs, so we always think this is coming from the neck.
Right.
Okay, it ain't coming from the neck. Okay, we've got to untrain ourselves from thinking that everything is coming from the neck when it's not. Okay, Richard, what is the sensory distribution of the musculocutaneous nerve?
I don't know.
Okay, somebody help them out. You will learn this. What is the sensory distribution of the musculocutaneous nerve?
The lateral antebrachial.
The lateral cutaneous nerve of the forearm. So where it, where's the skin that
That's in the forearm.
that's in the lateral forearm. Okay. What provides sensation in the center of the middle deltoid?
A branch of radial nerve. I don't know.
Nope. Where is axillary? Who said axillary?
Jennifer.
Jennifer. 2 points. Axillary.
Good, you can add that to my next report.
Yeah, we'll talk about it. The cutaneous distribution of the axillary nerve is a small oval-shaped patch of skin in the center of the middle deltoid. Okay, yeah, so that changes things, doesn't it? Okay, so now what are we thinking? Putting that piece of information together with the fact that he's got such atrophy of his deltoid.
There definitely seems to be an axillary nerve issue.
Yeah, so now we're starting to hone in on this could be an axillary nerve. Okay, so let's do some nerve conduction tests. So again, guys, this is a table that you're not used to, but don't worry about it. Okay, don't know why I checked the duck. I have no idea why I checked the duck. Okay.
Because ulnar is.
Yeah, maybe because we had, some paresthesias in that fifth digit. But does the duck supply sensation to the fifth digit? Somebody tell me where the cutaneous, distribution of the duck is.
The dorsal part of the hand.
Yeah. Dorsal hand over the fourth and fifth metacarpals. Okay. So also, suspecting that this could be a plexus issue, I checked the medial and lateral, cutaneous nerves of the forearm in very nice amplitudes. I checked his median nerve, of course, over 14 centimeters, everything looked good. But when I shortened that segment down to 8 centimeters, got just some borderline slowing of that short segment through his carpal tunnel. Also checked the ulnar nerve, and lo and behold, we have some prolongation of his sensory latency and some slowing there. Okay, so definitely a couple things that may be pointing again to a more distal nerve entrapment that may or may not have anything to do with his shoulder problem.
Right.
Okay, so did some motor tests here. Okay, and again, I just noticed, because this is how into it I am after a long day in clinic. I'm asking you what's wrong, and I've sort of listed it over here on the side, here for you. Okay, so median nerve, we have a significantly prolonged latency here. Okay, so we have a sensory and a motor issue with his median nerve at the wrist. But this is interesting. His ulnar nerve, not only did he have some just sort of borderlines flowing across the elbow, but look at his distal latency for that ulnar nerve.
Oh, yeah.
Okay, so that's fairly significantly prolonged also. So, with his amplitudes fairly well maintained, he could have, with his ulnar nerve, he could, have a little ulnar neuropathy at the elbow. He could potentially have a little bit of Wyoming syndrome here also.
What's that?
What is Wyoming syndrome? Okay.
Yeah.
Is Kathy Blair? Kathy's still on the phone here. Wyoming syndrome is basically ulnar neuropathy at the wrist. I have seen more ulnar neuropathies at the wrist coming out of Wyoming than I have in almost 25 years of doing this. Okay. Now, granted, I'm being sort of facetious here. I don't think all of them are true ulnar neuropathies. I think some of them are technical. But since I did this, I'm fairly confident that he's got, that he may have a little ulnar something happening at his wrist. Okay. But that, guys, that all pales into comparison to when I checked his axillary nerve. Okay. Latency side to side and as an absolute value look just fine. But look at those amplitude differences. This here is, this is your money shot. Right here. We got a 90% difference in amplitude side to side. Okay. That is not disuse atrophy, is it?
No.
No, it's not. Okay. This gentleman has a significant axonopathy affecting his left axillary nerve. This is very significant here. Okay. So seeing this side to side difference, somebody tell me what we're going to see when we do needle EMG.
Fibs and positive sharp waves.
Increased
Deltoid.
insertional.
We're going to see it in the deltoid. What other muscle are we going to see it in?
Teres minor.
Teres minor.
Teres minor.
Okay. What other needle EMG abnormalities could we potentially see with this much of a side-to-side amplitude difference?
Decreased recruitment.
Decreased recruitment. Okay. And, let me just talk for a second about the term decreased recruitment. What does decreased recruitment mean?
That you're not recruiting additional
motor units.
Yeah. It's inability to recruit motor units. What other needle EMG abnormality that we see also is considered to be decreased recruitment?
Fast firing.
Okay, so those of you that I mentor, you're going to learn, instead of saying decreased recruitment, I want you to be more specific. I want you to say, if the patient isn't bringing in more motor units, I want you to say reduced numbers or decreased numbers of volitional motor units. Or if they're fast firing, say fast firing. Okay, that really helps. And oftentimes the two go together. In a severe axonopathy, you'll see 2 or 3 functioning motor units that are firing at 30, 40, or 50 hertz to try to generate strength in that muscle there. So let's look. We've talked about the EMG results. Let's take a look now and let's see what we're seeing here. So I checked middle deltoid, checked anterior deltoid. Don't know why I checked anterior deltoid, but I did. Okay. Maybe because on exam it maybe looked more atrophied than the rest. Then I stuck his teres minor. Okay, so examined both branches of the axillary nerve, significant denervation in those muscles. Also starting to see some polyphasic motor units here. Okay? So after only a couple or 3 months, what process is going on that would show us polyphasic motor units after only 2 or 3 months?
Collateral sprouting?
Collateral axon sprouting.
Sprouting, yeah.
Exactly right. And because he's had such a significant axonopathy, just not generating a normal number of functioning motor units here. Okay, so a very profound injury to his left axillary nerve. Okay, so obviously, in terms of an impression, I call this a severe motor axonopathy affecting the left axillary nerve. Okay, now let's talk about something else here. Whoops, yeah, here we go. What other process might cause this amplitude to be so low?
Conduction block.
Conduction block.
Conduction block.
Conduction block, okay? Unfortunately, we're only able to stimulate at Erb's point, which is going to be proximal to the site of that lesion. We're not able to stimulate distally, okay? So that being the case, it's going to be important that I see him again in 4 to 6 months to check to see if those amplitudes are changing. In 6 months, if his amplitude has gone from 1 to, say, 3 or 4, what that's telling me is that there is a conduction block component to this also. But in 4 to 6 months, if his amplitude is still low, then what that's telling me is that it probably is a motor axonopathy. And that, of course, significantly changes prognosis.
Dr. Brooks?
Yes.
Sorry, this has been done since, after how long of the injury?
When did I see him? Was it December? I saw him in October. Yeah. And so
1 month.
Yeah, and so this was done about, I want to say about 5 weeks after that. Okay.
One question, Dr. Brook.
Yes.
If it is conduction block, then in 1 month, do you see this much changes in EMG?
No, all of this.
No.
Yeah, all of this is due to an axon loss component here. Okay, but he could injure 30% of his axons and still show this. Okay. So at this point, I'm not sure. I think I'm going to see him. I think he's scheduled for March or April, or something like that. And we'll see what things show, when he comes in, at that point. So, yes.
If you said his if it got up to like can you go back to the slide where you said if it got up to like 3 or 4? I'm trying to remember. Yeah, if you said his amplitude got up to a 3 or 4, you said it'd be a conduction block. What would you, if it's not conduction block at all, would you expect it to stay closer to the 1? Is that what you're?
Yeah. If this is primary axon loss, he could recover some of his amplitude simply because his muscle is so close to the site of the injury. and there's the sprouting axons and the regenerating axons
Right.
don't have to go that far. Okay,
Right.
so the potential is that he could recover. What we don't know, again, like I said, is one, is there conduction block, or is this still ongoing? Okay, is there still something in that shoulder joint, that could be compressing this nerve? Okay, we don't know. Okay, because at least at the last time that I saw him, he had an MRI, and what they were looking for is to see if he had any labral issues, but MRIs are notoriously bad for not picking up, soft tissue compressions there. So, again, here in a month or so, we'll stick him with a needle again, and we'll recheck this nerve. If he's getting better, fantastic. If he's still at 1 or 2, and he's just not gotten better, then that prognosis starts to get a little bit worse there. Okay.
Thank you.
One question, Dr. Brooks.
Yes.
If it is conduction block, and if that patient waits another 4 to 6 months, are there chances that conduction block, because of this much longer time of compression, it will convert into axonal injury?
It certainly could. Okay. If the source of compression is not removed, then certainly you could start to see a loss of myelin and then ultimately a loss of axon. So chronic compression certainly, could cause, ultimately an axon loss. In his case, what do you think, hypothetically, is causing this conduction? What do you think might be happening on a physiologic level that is causing this on a conduction block? Because conduction block doesn't mean that there's, necessarily that there's compression. Okay, what could have happened to cause a conduction block in this case? What is the most common cause of axillary nerve injury?
Dislocation.
Anterior shoulder dislocation.
Dislocation.
Yeah, followed second by humeral neck fracture. Well, he didn't have a humeral neck fracture. Very, very possible that in this MVA that he dislocated his shoulder, because he's not a big guy. Anyway, 6 foot tall, 155 pounds. Not a big guy. Okay, so let's just assume that he had an anterior shoulder dislocation. What in that process of injury, in that mechanism of injury, could be causing a conduction block? And you have to sort of switch your mind down to a neurocellular level and think about what is going on here.
Could it be like significant inflammation in the area? Or?
It could be inflammation. Most likely what happened is there was a stretch injury to this nerve. As the shoulder pops out of socket, it stretches that nerve. So that stretch injury mechanism not only compromises the axons within the endoneurial tubes, it also will compromise the myelin. It will damage the myelin, which will become inflamed, which will undergo necrosis and be cleaned up. So that conduction block could be over that focal segment where that myelin got stretched and is just not able to to perpetuate that action potential because of that myelin injury. Okay, loss of entire segments of myelin, and most likely in that same area are where those axons were stretched and became damaged, underwent Wallerian degeneration, and that's why you're having the needle EMG abnormalities. Okay.
Dr. Brooks?
Yes.
Do you know if he was driving or a passenger?
He was an unrestrained passenger.
Okay. Because the seatbelt coming across the shoulder could give you a little bit more.
It could. Most likely what I think might have happened here, he wouldn't admit it. There was probably a little alcohol involved here on these guys' part. Okay. And most likely when he saw what was going to happen, he probably tensed up, grabbed the seat, grabbed the handle, and then upon impact, his arm got jerked and probably got dislocated, and ended up fracturing his forearm also. Okay, but again, we don't know. We don't know. Other sources of injury include blunt trauma, stretch injury, penetrating injuries such as gunshot wounds, stabs, compression in that quadrilateral space due to fibrous bands. Weightlifters oftentimes will develop quadrilateral space syndrome because of muscle hypertrophy, cysts, lipomas, hematomas, injection. There are documented cases where people have injections into their deltoids for a vaccine and have damaged a branch of their axillary nerve. Okay, I've seen one or two cases where that middle deltoid is collectively atrophied, where the anterior and posterior are not, and that injection damaged the branch of the nerve that supplies the middle deltoid. Okay. So again, in terms of the pathophysiology, in an axillary nerve injury, where is the paresthesia going to be?
In the middle deltoid.
Middle part of the deltoid. Yeah. Okay. Weakness in flexion, weakness in abduction, but less weakness into internal and external rotation. Okay. Differential diagnoses for axillary nerve injury include processes such as rotator cuff or labral pathology, radiculopathy, C5 or C6, brachial plexopathy, thoracic outlet syndrome. So there's a lot of differential diagnoses. Okay? And that's where our electrodiagnostic tests and ultrasound can help to rule in or rule out exactly what's going on and allow us to manage these patients better. Okay, so let's talk about prognosis here. On its face, a 90% decrement side to side CMAP amplitude is not good. Okay, you all have heard Dr. McKibben talk about pruning a bush. Okay, if you prune a third of a bush, or you prune half a bush, or you even go up to 70-75% pruning of a bush, there's a good chance that everything's going to go, grow back. But when you prune back 80 or 90% of that bush, it's probably not going to grow back because there's not enough surviving limbs and leaves to allow healthy regrowth. So if you kill off 90% of your axons, there's not enough axons left to sprout to give you a satisfactory recovery here. Now, that being said, we're not sure if there's a conduction block component to this. And in the 3 to 4 or 5 month range, as inflammation subsides, and that the myelin remyelinates, if his amplitude increases nicely, then his prognosis to get better is much better. Okay. When I see him here, 4 to 6 months down the line, and his amplitude is still 1, 1.5, or 2, I'll probably see him back in another 6 months just to do that nerve test and just stick that muscle. But then our prognosis becomes quite a bit more guarded at that point. Okay. Okay. It's 8:30. This next case I'm going to do is probably going to take us 40 minutes to get through. So I'm going to stop. And I'm going to I'm going to open it up here to any questions, not just about these cases, but about anything in general as it pertains to electrodiagnosis.
Dr. Brooks, I have a question.
Yes, sir.
You said in this case, ultrasound might be very beneficial, ultrasound diagnostic test.
Uh-huh.
How does that, can you explain on that, please?
On what the benefit of doing ultrasound would be?
Yes.
Yeah. Certainly that could help establish if there's any other type of pathologies occurring, such as rotator cuff tear, subscapularis tear, bicep tendon tear. Okay. It'll also allow us to visualize that deltoid muscle, right? So a muscle that is actively denervated and is becoming fibrotic, how's that going to show up on ultrasound? Vicky should be able to answer that because she's she's fellowship trained in ultrasound. So
yeah,
I
it
mean, so
shows it
tell us
much
what a
darker.
denervated muscle. Yeah.
Yeah, so you've lost the kind of what's considered the marbling effect in the muscle because you don't have as many muscle fibers, so it shows up very dark. On ultrasound.
Yeah, the muscle fibers get replaced with fatty necrotic tissue. Okay, and those type of tissues are strongly hypoechoic or anechoic. Okay, so they're not gonna look the same as healthy muscle. They're not gonna have that marbling effect. Additionally, when you look at the thickness of the muscle around the shoulder joint, it's going to be very, very thin. Okay, if you remember from class here a couple of weeks ago, in a healthy deltoid, there's a pretty good amount of muscle there. But if that muscle's atrophied, and then especially if it's starting to show, that there are anechoic changes, then again, that's indicative of undergoing fatty necrosis, and that also is not a good sign.
Thank you.
You're welcome.
It also can show you if there's something else going on, like a space occupying lesion, something like that.
Yeah, you should be able to pick up things like a cyst, maybe in that quadrilateral space, things like that. Okay. Other questions?
Dr. Brooks.
Yes, sir.
With those two patients that you had the one lady, and she looked like she was a little bit bigger and a little bit more out of shape, and then you had the younger individual who looked
very fit.
Fairly in shape. I mean, to me, even before you do that, you're thinking definitely with him. I mean, to me, I know this is not so much of a question, but it just seems like you would be somebody that you would more likely think this is more of an or some kind of nerve-related issue for sure. I'm sure you may not know as much because it could be just more deconditioned. She looks like she's in general poor health, where he looks in good health, and you see this one glaring, this is terrible right through here.
Right.
I don't know. That's just me.
Well, basically what you're saying is there's not a lot of overlying tissue that would hide the fact that his shoulder girdle is significantly atrophied.
Right.
Right.
Yes. Yeah, pretty much.
Yeah. Absolutely. Absolutely. Okay. What could I have done different in my tests? Are there anything that you guys would have done different that would have made it made a change in our final impression?
thought you were pretty detailed. I think I counted 16 muscles that you
Yeah.
EMG'd,
Yeah.
which I think would have taken me like over an hour to do all that. So
Yeah. Well, and again, in his case, let's go back to here. You know, I'm trying to, of course, cover axillary nerve, musculocutaneous nerve, radial nerve, suprascapular nerve,
right.
lung thoracic. You know, I'm trying to cover all my bases. But let me tell you something. When you have somebody this abnormal, it don't take long to analyze that muscle. You stick that needle in and boom, your screen is full of abnormality. Okay? So I move it to a different segment, stick it back in. Screen is full of abnormality. Okay? I'm not going through 6 or 8 quadrants here. And then I'm gonna look at recruitment. I mean, I probably had a needle in his deltoid for less than a minute here. Okay, so again, that's a great point there, Mark, is we don't have to spend a ton of time doing this. If there's abnormality and you stick that needle in there, it's usually going to find you. I mean, you're not going to have to go to 6 or 8 or 10 quadrants to try to find something.
Right.
There. But I wanted to cover all these shoulder girdle muscles. I wanted to cover upper trunk lateral cord, and I wanted to cover cervical spine here.
Dr. Brooks,
Yes, ma'am.
for EMG, I mean, from these, which muscle you can exclude? I mean, then you don't have to stick needle too much, but it's enough to.
Yeah. I mean, I probably did not have to stick the extensor digitorum there. I probably would have left that one out. I probably didn't have to stick the anterior deltoid because I already had, an anterior branch muscle or an anterior branch and a posterior branch. Biceps and triceps, I would certainly keep in, to cover cervical spine and plexus. Pronator, because he had that carpal tunnel, I wanted to check. A proximal, median, integrated muscle. So yeah, I probably could have lost maybe 3 or 4 of these sticks, and still gotten to the final conclusion.
I'll tell you later. I'll tell you here a little bit.
Okay, so just to give you an idea of what's coming up.
Dr. Brooks?
Yes, ma'am.
I just wanted to say one more thing, talking about musculoskeletal ultrasound.
Yes.
Is that you can actually visualize some of the nerve roots in the brachial plexus as well with this particular, this particular guy.
Yeah,
you might.
and so since you bring that up, what are you going to see in, say, a plexus lesion? What might you see when you do your ultrasound of the plexus?
Well, you may see darkening and increased enlargement of the nerve.
Yeah.
Enlargement
Yeah,
of the
you're going to see an increase in that cross-sectional diameter. You may see some changes in the echo density of that nerve. Exactly right. So next time we get together, this will be one of our patients that we'll talk about. Looks fairly similar to what we've been looking at already, right? And I'm going to fly through this. Look at this guy.
Oh, yeah.
Okay. Fly through that. And here's our other guy. So we'll talk about these last 3 cases next time we get together here.
That's good.
Okay. And they're all different, but they're all presenting with the exact same presentation of atrophy, pain, limited motion, weakness, loss of function here. But they're all significantly different injuries, but they all look the same and they present the same. This is why it's important that we have these tools available, okay, so we can adequately treat these patients. Some of these patients, 1 or 2 of these, we're not going to get better. Okay, we're just not going to get better. And you know, and we certainly want, you know, with the sort of limited resources that we're starting to experience with therapy, is we want to, you know, be able to efficiently be able to treat our patients here, and to efficiently treat our patients. It's super important that we know what's going on up front here.
Yeah.
Okay.
Hey, Dr. Brooks, thank you very much. This was
Thank you so much,
really
Dr.
good.
Yes.
Very
Oh,
helpful.
awesome.
Good night, everybody.
Thank you.
Yep.
Thank
And
you,
I'll
Dr.
see you
Brooks.
all here in about 4 weeks when we will
Sounds good.
continue our journey of the shoulder here.
Excellent.
Okay.
Hey
Great.
guys,
Look forward to it.
take care.
All
Bye-bye.
right. Bye.
Okay.
Thank you.
Bye. Good night, everybody.
Good night.